Hello, everybody. Greetings from all around the world to each and every one of you. I know quite a number of you are in Europe. Good afternoon to you, and to my friends and my colleagues in Asia. Good evening, and to my friends in Australasia, Edwin and Howard. Good night. I think it's probably your big time, but yeah, thank you for making time for this lecture. I'd like to take this opportunity to also thank Diego for his very patient arrangement to make this seminar available today. And I would like to use this opportunity to share my personal experience using the autogenous tooth graft augmentation. And many of you who have been recently following the AO, the Academy of Osseointegration, you have perhaps you might have listened to one very interesting lecture by Professor Frank Schwartz from University of Frankfurt, talking about his approach of using autogenous tooth graft. So you have seen that this interest have been picking up over the last few months. In fact, the last few years, if you look at the publication, the number of cases, articles that have been published have been increasing steadily. I'll be breaking the seminar into 3 parts. The first part will be a very quick, simplified overview of the choice of bone graft, the type of bone graft, and I will not spend too much time on that. I know many of you are already experienced in implantologists or even surgeons. And then the second part, I will talk about the slight change of the characteristic of surgical technique, which I have employed in my practice for the last 12 years. And I'll be showing you also clinical cases related to that. And of course, very importantly, the characteristic and the scientific evidence of the use of tooth as a graft material and the approach and the literature that supports it. And last but not the least is the most important part, which most of you look forward to, is the clinical application. In my approach, I have expanded a final part, which I will specifically talk about periodontal regeneration, which myself and one of my co-colleague, Dr. Simon Ng, both of us have been doing about close to 30 cases and follow up to 4 years on periodontally diseased teeth, and we are able to create some interesting result. I hope I'll be able to hold you to the very end. But please indulge me for this very moment. I'd like to let you understand that while some of you coming into the seminar purely out of curiosity, or some of you are here because you are having some doubts, I'm okay, I'm fine. I'm willing to be misunderstood, because this is something very unconventional right now to many people, and a lot of people will think that this is something that perhaps is experimental, but to quickly tell you, it's not. And just before I start the lecture proper, please indulge me for a couple of seconds on this very interesting ad. I hope you can listen to the video.
Here's to the crazy ones, the misfits, the rebels, the troublemakers, the round pegs in the square holes, the ones who see things differently. They're not fond of rules, and they have no respect for the status quo. You can quote them, disagree with them, glorify or vilify them. But the only thing you can't do is ignore them, because they change things. They push the human race forward. And while some may see them as the crazy ones, we see genes. Because the people who are crazy enough to think they can change the world are the ones who do.
So obviously this video tells you about doing things differently. It challenges the norm, and we know what the norm is in our day-to-day practice, dealing with bone augmentation or dealing with teeth that are severely destroyed because of periodontal disease. A lot of the alveolus housing have been destroyed. We know the steps and the painstaking procedures we have to do, dealing with possible complications, patient discomfort in order to achieve the results. And very often this takes a long time to reconstruct back. And more often than not, we may not get the results that we want, and we get a little bit concerned. But when you manage it, understanding the biology, taking it one step at a time, you can create a pretty decent result, and also a result that is long lasting. It is important for us to, first of all, always remember these two keywords: respect biology and think biology. We must always be the one supporting the biology of the human body, not the other way around. The material at the moment now in the market has been limited in terms of many of its applications and its ability to do some of the procedures. But of course, in due time, in this lecture, I hope I will open your eyes and hopefully give you a better perspective of new possibilities. So very quickly, the choice of bone graft that we have is essentially based on two key components and two factors. It depends on the osteogenicity of the recipient side and the osteogenicity of the graft. It may sound very simple, but in reality, if you choose to apply this theory into different graft sites, you sometimes find it very difficult to decide on whether the recipient site is really a very good site or it's not such a good site. But in extreme cases, of course, it's very straightforward. And most of the graft materials, other than autogenous graft, lacks a lot of osteogenicity. So it is a fine balance between these two factors. So in a very simplistic way, in a highly osteogenic site, we could use graft that are just a scaffold material, which provide nothing more than just minerals and support. And these are really the low osteogenic graft materials. And when sites becomes more infected, site that has been more destroyed, multiple infections before, then the need for more osteogenic bone graft material, is preferred. And this clearly is what a lot of clinicians will have told us, and we are following this thus far. Well, this will make the treatment for the patient a little bit more complex, which is why more often than not, as clinicians, we like a more simplified idea. Perhaps we have a silver bullet that can solve all our problems, but in reality, we know it's not true. We are bound to have majority of the cases being able to be sorted out with one particular type of bone graft, but sometimes you need other graft material just to enhance the outcome of your cases. And the fact is that in a healing process of the bone, over a period of 4 months, consolidation, and then finally a process of maturation over up to 6 months, is a complex procedure of both blood supply and the right cells. They are all in a very well cascade sequence. It is not a haphazard process, and therefore to think that if we put a bone graft at the beginning when it is not playing its part, then you find that the bone graft serves not the purpose, but much later on. I will try to describe this later on in the periodontal regeneration. You will understand this a lot clearer. But understand that in bone healing, whether it's just bone per se or with periodontal regeneration, it is a complex process. So we need all the supportive elements of blood and cells. When we have a consolidated graft, it's very easy to see. Of course, as clinicians, we may think that, okay, it follows a period of time, but in reality, you really can only see it when you raise a flap. You can see a decrease in characterization from its original form. You want to have bleeding coming from your grafted side. The graft should be well fixed. When you drill into the bone, graft and chunks should not be flying out or dislodging in big blocks or big pieces, which means that the graft has not actually taken. And sometimes radiographically, you may have a graft that consolidate and become homogeneous with the native bone. That would be ideal. But many a times we can see that many of the grafted bone that we place, the radial opacity outweighs the radial opacity of the surrounding bone. And sometimes this just means that the graft material has still been still existing and is still in its state of turnover that is still quite minimal. And in cases where some of the bone graft you place over a period of time, there should be increase in opacity, especially when the graft originally are more radiolucent. So these are some telltale signs to show that your graft has consolidated. Just like this case that you see, a graft that we have placed to augment a lateral deficiency with allogenic bone graft material. You can still see chunks of existing placed graft material that has not undergone complete resorption, but you can use a periosteum elevator, you can scrape it really hard, it will not come off. You will see the bone, it should be bleeding from all sides, it should be solid, and when you drill into the bone, it should bleed. And this is essentially something we like to see in our clinical cases. However, there are some situations when you can see on the case on your left, you can see the placement, the drilling, the lack of bleeding, and then when inserting the implant, you see the graft falling apart, and you can see granules existing, peeling off. This is not something I would like to see in my clinical cases. So I always have a situation, if I have a situation like this, my main concern is how much of this graft is actually taken, how much of this graft is alive. And actually, if you look at the histology, you'll be quite interesting. And I'm sure many of our colleagues in the room have done a lot of histology with their grafted cases, and they will be able to share also very interesting results with you as well. Whereas on the right is a case that I did an allograft material. We did a lateral augmentation. After the grafting, after drilling, I could use a bone spreader. I could spread the bone. The viscoelasticity of the bone was pretty impressive. With the bone spreading, I could then expand the bone and insert an implant. So these are things that we want to see, a bone graft material that can behave close to the physical characteristic and the biological characteristic of the native bone. So what do we really want from the graft? It's very simple. Very quickly, I just use a reference. We know this long time ago, we want graft material that is osteoconductive, and this is the basic fundamental characteristic of all bone graft. If it's not osteoconductive, none of the osteoinductive characteristic will exist. But if your graft is at least osteoconductive, it is available to become osteoinductive, to recruit mesenchymal cells, to transform into useful bone-forming cells would be great. Of course, the bone graft that is consolidated, it should be undergoing remodeling, mature over time, and can stabilize your implant and prosthesis with the grafted site. Of course, you want a graft material that has a low infection, easily available, which we know that some of these situations are not available with especially autogenous bone because of the risk of surgeries, even though we have good osteogenicity with those bone. But we know that the risk is higher because of the morbidity of the surgical procedure. So when you look at the graft placed in the extraction site or placed in the regeneration site for implant placement and regeneration, I show you here 4 clinical scenarios, and if you choose these 4 cases, which outcome would you prefer? And many of you would have probably already seen straight away, the top 2 cases shows you a lot of granules that are still stuck to the soft tissue, and in fact, over a period of time, they get exfoliated out, which is not what the body should do. It's a graft material that is well received, well consolidated. It should actually be accepted and not exfoliated. The difference between the top 2 and the bottom 2 is that the top left is we use what we call a bovine HA, and then on the upper right is an allograft of cortical nature. But the 2 at the bottom, you can see that the sulcus area, the soft tissue is beautiful. You can, on the lower right, it shows the allograft making up of cancellous nature predominantly, and on the lower left is made up from the patient extracted tooth. So you can see that the behavior that I would like to have is those on the bottom, where the soft tissue reaction is just as good as with the bone, which I will show you the clinical pictures later on. So when we look at the biological property of various bone graft material, as I mentioned before, the 3 characteristics that we really want, you'll find that the autogenous bone graft has been considered the gold standard, or is it? That's a big question. So we will have to look at some of this graft material. We'll classify it into different categories, as we can see, there are 4 categories, and we'll now try to dissect and look at their properties. So the first thing, when we look at all those synthetic materials, and even from animal HA predominantly for bovine, we have also from plaster of Paris and calcium phosphate materials. There are a lot in the market. So how do we choose? How do we decide? It cannot be just based on price. It cannot be just hopefully based on your only availability. It should be based hopefully on your scientific decision. And of course, with even just using the bovine HA, there are selections, and how do you choose which to use? Certainly, we are very spoiled in terms of all types of graft materials in the market, isn't it? So what I have done over the last few years in my clinical practice and in my early development, leading to subsequently using what I'm using today, which is using tooth as a graft material, I've been using heavily lots of bovine HA. And when you do a lot of bovine HA, you will also have some very interesting experience. And we have used a lot of cases for immediate implant placement and immediate tooth replacement in these cases. Follow-ups are beautiful in quite a lot of the cases, but what really made me felt pretty uncomfortable, and actually it disturbed me over the years when I follow up in many of my cases. And you can see radiographically, and this has been followed up. This case has been with me for more than 10 years, and seeing this white stuff, white density, radial opaque around the crestal area of the implant, this bone, which is highly porous and non-resorbed, and over the years, you have small little spicule exfoliating out. It's a big concern to me. My question is, what is the body reaction to this in the long run? Well, in this case, everything turns out fine. Once in a while, the patient comes back with a little white spicule and he tells me there's some little white stuff coming out. We remove it, we flush it, and things are fine. But in the long run, I'm not sure what will happen to this case. What happens if there is a biological challenge and there is a spread of any infection down the crestal area in a very porous situation like this? Will this be a area with a labyrinth for infection to spread really fast? This is a big concern for me. So and I also seen it in cases when I want to use this case to illustrate when we try to put the bovine HA for lateral augmentation. This is conventional drilling and bone spreading and placement of the implant. We did a sandwich technique, which was very popular many years ago, and I think it's still done by quite a few clinicians today. You take the autogenous bone on the buccal and then further augment on the lateral aspect with a bovine HA and a membrane over it. Even so, with all these cases, consolidation of the graft, in this case, we still have to manage the soft tissue deficiency. I had to further perform a soft tissue procedure. But when I have this opportunity to open up the flap, I could see that the granules that were placed laterally, the hydroxyapatite, has not resorbed. In fact, it is there, and if you use an instrument to scrape over it, chunks of it will fall off. It's just merely acting as a soft tissue plumbing device, and also perhaps just some fibrous integration around the area. And if this is so, the question is what it did inside and around the implant. So that is also a concern for me. So we did a soft touch procedure, a vascularized interpositional flap, and then we augment the tissues and thicken the tissues up. We finished the case. So because this case, the implant is completely enclosed within the healthy autogenous bone, I'm not so worried. The hydroxyapatite is essentially acting as a support for the buccal aspect of the tissues. And this is the case after 16 years, the tissues are still very stable. And so the hydroxyapatite that we use, that doesn't resorb, maintain a very good volume in many of our cases. That's the major advantage that I see. But if you look at some of the recent literature over the last few years, I'll just pull out a couple to one or two to discuss. We are looking at all this evaluation of extraction socket filled with the bovine-derived bone graft. They found that actually they can actually delay or interfere with the consolidation of your site. And in fact, if you happen to pack very fine granules and you pack it very tight, I think you might experience some difficulty with your outcome when you try to go in again during the re-entry to place the implant. Perhaps some of you will be able to share some of your experience with us. So this is a case that I received from a colleague who told me that the patient had a socket augmentation done with the hydroxyapatite, bovine hydroxyapatite and the membrane, as indicated by many clinicians. So everything went well. The patient came back 2 years later and said, "Doc, I'm ready to have an implant. Could you do something for me?" And when we raised the flag, it looks really beautiful. I think none of you in this room will have disputed with me that the site looks beautiful. The ridge is well consolidated. But just before we start the surgery, we decided to scrape the surface. And from the X-ray, you can see a good you see the graft is very dense, very tight in the area. The whole ridge is very well maintained as reflected on the clinical picture. But when I start to touch the surface, I was finding a little spot. It got softer and softer and softer, and chunks of material came out just by scraping with minimal force. And we end up having a socket as how the patient started with. It is, unfortunately, I would say in a very cheeky way, is a socket preservation technique. We do not want a socket preservation, we want a socket augmentation. So in this case, the patient had to start all over again. The 2 years of waiting has been wasted. For some reason, the patient has waited such a long time to decide to do his implants. And this is a situation the patient have to deal with. It is very disheartening, especially when they've gone through so much. So we have to change the way we think. What we have been told by colleagues, perhaps we learn from our teachers, including myself through the years. We use our own clinical experience and to also try to ask ourselves, are we doing something right or are we doing something wrong? Can it be done better? And it is a very necessary thing for us to only expand our horizon and improve ourselves. Sometimes purely from just observation, we can get the answer. And clearly, Leonardo da Vinci has clearly just purely by observing have realized that the Earth is not the center of the solar system, but we are just one of the orbiting planets and the moon orbiting around us by observation, instead of listening to what the authorities told us what it is. It is critical for us as a clinician to be both critical but also accepting. So we must have a very healthy and attitude towards information. We all know that the property of bone healing requires all this already. So what we have been told all these years is that autogenous bone is the gold standard. Barrier membrane is absolutely necessary for GBR. And you definitely need a tension-free closure with no early flap opening for successful GBR. I think many of us who are listening to this right now perhaps share the same view. And I held this concept for many, many years until when I decided to read literature that are not dentally related. And it started to change my mindset. And I will share with you some of this literature along the way. So what's wrong with using a membrane? Is there anything wrong with using a membrane? We have been told using a membrane, everybody does it. The gurus do it. Your teachers, they do it. Your seniors, they do it. Your bosses, they do it. You did it. I did it. What's wrong with using it? But the question is it necessary? What is the function of the barrier membrane? We have been told it's a barrier, so yes, it should work. It should be functioning as a barrier, and we know why it's supposed to do, what it's supposed to do, but is it really necessary? In fact, when you put a membrane actually inhibits the blood flow, the perfusion in the flap, once you cover over the grafted site. And it's very interesting today because the graft companies, the membrane companies that tell you the membrane is the barrier membrane today are starting to tell you their membranes allow the blood vessels now to creep through their membranes. And to think that many years ago, or even up to this point, they're trying to prevent all these undesirable cells to go into the area. It's interesting, but nonetheless, what I'm trying to highlight to you is that when you put a membrane, you actually stop the blood supply coming from the mucoperiosteal flap. But what are you actually stopping? You're not stopping the soft tissue, you're stopping the periosteum. In fact, when you use a titanium micro mesh, which have huge perforation, which have holes way bigger than the cells, it has no barrier effect. It has no barrier protection to the grafted site, but it works. It makes us think all over again the effect of barrier effect. Is it purely a barrier effect, or is it just a space maintainer? And in fact, this article is quite interesting. They make a barrier membrane which has a part that has perforation and a part without perforation. And in this study, they found that whether you have a perforation or you have a complete obliterated membrane without any perforations, the result is more or less the same. So the question about having a total blockage is maybe not such a big deal. What I have highlighted to you early on about the periosteum bring us back to the first basic understanding of the role of the periosteum. The periosteum has such a big role in our bone augmentation procedure. In fact, it is one of the key ingredients when it's stimulated, when the periosteum is stimulated, stimulate bone formation. But what we have done with a membrane is to cut off the role of the periosteum, unfortunately. And if you look at other literature in terms of anatomy, articles on anatomy, articles related to biological research, a lot of focus was actually on the role of the periosteum. And when the periosteum is active, it helps bone formation and bone repair. And in this article, the periosteum that was placed created a positive impact. And the periosteum has cells, and these cells, when they are blocked, will be prevented from helping the graft to become better regenerated and get better outcome. So the idea is not to block off the periosteum and all its progenital cells. In fact, there are lots of rich cells, there are stem cells and even osteogenic cells that help our graft consolidation. In fact, when you remove the periosteum, 73% decrease in new bone and cartilage formation, and a tenfold decrease in neovascularization. It's incredible. And the absence of periosteum also resulted in a reduction in osteoclast numbers. Well, the question is, why would you want osteoclast? Because if there's no osteoclast, there's no osteoblast activity. You want good bone remodeling. So I would like to take this very short moment to just introduce you a concept which I apply to all my clinical cases, even now with the tooth graft material that I'm using. We're doing this thing called the periosteal guided bone regeneration concept. In the membrane is periosteum, which guides our bone formation. Very quickly, the periosteum, under the histological, you understand that there's two layers. There's an inner cambium layer and an outer fibrous layer. The cambium layer sticks to the bone by Sharpie fibers. Do you realize it looks just like the periodontal ligaments? It has the same connection. And when you look closer, the inner layer where the cambium layer area is very rich in cells and blood supply. And this is something we should be using and not cutting off. And this is just to show you under histology, the cells that are available next to the bone. So the periosteum bone, that is the periosteum that's stuck on the bone, when you peel it away and you do a tension-free closure, while in your mind is tension-free, I don't lose my graft. But because it's tension-free, the periosteum becomes inactive. While we are trying to use the periosteum to form new bone, stimulate it, by doing a periosteum release, you essentially deactivate the process. So the periosteum, while has good cells, good potential for bone formation, this is essentially reduced when you do two things. One is a periosteum release, which is all of us are very familiar with. And the other one that is done quite commonly now by a lot of clinicians. In fact, quite recently, I heard quite a lot of interest is this brushing of the periosteum. What you are brushing away is a very important layer on the cambium layer, which is very rich in those cells. So personally, I don't do any of this procedure so much nowadays. In fact, I barely do it now. So I'm trying to respect the role of the periosteum. Can I create space without periosteum release? Absolutely, we can do that. I will. I think I might have this in the presentation to show you. So how do I stimulate the periosteum? Are there many ways to stimulate periosteum? Yes, there's actually only one way. They found that in this study, they did a very interesting result. They did test the periosteum effect with different things. When you have only static pressure, meaning tension-free, you have slight effect. Okay. However, when you increase bending strain, there is a stimulation for bone formation. This bending strain happens when you raise a flap, and when you try to pull it back and close, there will be some bending and tension. It triggers the periosteum effect. So without doing periosteum release, but you do a larger periosteum flap, meaning you free your flap a lot more, that creates the space for you to advance your flap without any form of scraping or cutting or manipulation of your periosteum. You can still get a closure of your flap with bone grafting. So this is what happens. You have a flap like this on the left with a defect, then you raise a flap. The more you tunnel your flap, the more you can advance your flap. And when you put the bone graft and you close the flap now, there is this tension, this bending tension to your periosteum. This will stimulate the bone formation. So often we do not do much vertical release. Number one, we do big crestal and we do long crestal incision as possible, and then we do a lot of periosteum release. We do a lot of flap elevation around the area, a circumferential flap raised, and we fill it with bone graft and close under mild tension. So a good case in point like this, what we did is we just placed only the allogenic bone graft. In this case, it's just allograft for this patient. And then we need not put any membrane. All I did was I closed it with PRF and placed over it. The PRF does not play any role as a barrier membrane, but merely for the soft tissue consolidation. And this is the outcome that we have for the patient. Well, I will not want you to guess. I will tell you straight away. This is the healing in 16 hours, 1/6. And we were able to subsequently raise the flap in only 3 months. Yes, we can still have some graft material still stuck on the surface, but they're hard, they're solid. We can drill and we can expand the bone and place the implant without any of the bone graft falling apart or blocks or chips coming off. So you get a very nice outcome when the bone are well consolidated and well remodeled. So the common technique that we have done to create the space, rather than depending on the graft, let's say you have a large area, we use these tenting screws. I have done this already for the last 12 years in my practice. And many of these cases that we've shown you has been done in our practice for more than 10 years. And using tenting screws is quite a routine. It's been done for many years. However, in recent years, I think there is a interest of this technique called the umbrella technique. Essentially, the tenting screws acts like an umbrella. The head is a lot bigger, so it provides a support for the soft tissue, preventing it from collapsing. So whether you have a case like this, where you have vertical, you have a V defect with a through and through to the lingual, well, same thing with the tenting screws. We can prop it up. You can put a longer one if you want it higher to the level of the native bone, and then at the lateral aspect, you can put the screws as well to support. And with this support, with there's pressure from the periosteum, there is no more resorption and no collapse of the site if this tenting screw providing mechanical support to the periosteum and soft tissue. And we can place the implant easily. Or in cases we see very often very atrophic or rather site that have tooth extraction in the anterior region for the lower mandibular anterior for a long time, you have resorption like that. We can easily place those tenting screws. Well, how much do you place out? You place up to the level of the buccal contours of your natural shape of your adjacent tooth as a reference. Never go out of the neutral zone because those will resorb away anyway. Once you put the tenting screws on, you can put the graft material all around it. And if you like, in my case that I used to do is to put some PRF membrane over it. This purely for soft tissue. I need to emphasize this. It does not provide any barrier effect and to help the soft tissue consolidation. And this is what we can have after 4 months. If you'd like to know more about this case, you can actually read the book that Professor Elio Minetti, who has actually published a book, and I'm one of the co-authors in the book. I have put up this case as a case study. So I hope you will take this opportunity to look at it as well. So this is what we have, by the way. You can see the head of the tenting screws visible, and this is what we can graft from the area, and you can see that. But you can see also at the same time at the lingual aspect, there is some arteries running into the lateral lateral aspect of the edentular switch, both on left and right. So I did not want to risk putting the implant on next to the adjacent tooth, but I place it in the center like this, so that we can cantilever to a pontic to the side. And this is a routine. Graft, tenting screws. If you want to, you put a PRF membrane. This is the effect. We always have overgrowth of bone around the tenting screw, and it's a good outcome. It's better to have more than to have less, and this is what we do. And now, of course, I do not do this with allogenic bone. I do this with the tooth graft very easily, and this is the effect. So again, I just want to tell you how easy it is to do, and this is what can be achieved very quickly. I do not want to spend my time here because this is not the main lecture topic. So this is what we do. This is the concept we apply to our technique. So you get a very good soft tissue and hard tissue contours and outcome. Well, the concern with allograft is that they are non-autogenous. Questions always about biocompatibility and risk of rejection. To us, it's a costly source, but I just found out from my orthopedic colleague, allogenic graft is actually very, very competitive priced, and they are actually very attractive in terms of price. Of course, there are concerns with the donor source and preparation, and especially in Asia, in Southeast Asia, patients are not psychologically able to accept taking cadaveric bone from other people. So these are the limitations. So searching for new alternative is definitely in the pipeline. So last one, of course, we talk about autogenous bone graft. It is the gold standard. We know we can take from all the chin or ramus or even from the hip. Well, these bones sounds attractive. It's a gold standard. We should be using them. That's what everybody tells us. Or is it not? Or is it? Whatever bone graft you choose to put, the key is blood supply. And if you now take out a bone graft from the ramus or from the chin, from the matter, and you are ready to put it on another side, it will take a while before you put the graft. The graft is actually now lack blood supply. The graft is actually hypoxic. And if there's any cells remaining, it will be hypoxic, and perhaps it might even cause the cell to die. And you might be just getting sterile bone with no osteogenic property. And if you're purely taking bone from the cortical aspect, how much of this osteogenic property do you get? Pulling an excerpt from the book, and I think most of you who are doing GBR would agree with me. This is one of the amazing books that have been published. And if you have not gotten this book, I strongly recommend that you do that too. Up at chapter 6, I just decided to pull up a little excerpt. It says, on the other hand, mandibular bone graft, which primarily consists of cortical bone and the low percentage of cancellous bone, are more resistant to revascularization and consequently have poor regenerative potential. Interesting. So if you now think that you have a poor osteogenic site and you think that you're getting bone from the ramus or the mandibular region, and you are thinking that you're putting a bone with high osteogenicity into a site of low osteogenicity, and you think you have bone regeneration? Yes, of course you can have, but I think it's more than just a factor of the bone itself. It is not just because it's autogenous bone. It has many factors in the whole equation of bone regeneration. If you look at this article where they analyze the cellular contribution of bone marrow to even fracture healing, using the bone marrow, and we're supposed to believe that the bone marrow is very rich in osteogenic property. They found that the donor bone marrow derived cells, which originated from there, did not participate during fracture healing. They could in fact contribute to inflammatory and bone resorption cells that are counterintuitive to what we are trying to achieve. So it's just a thought process for you. So I used to do these big procedures. I mean, it's not big to some of you. I'm sure some of you are doing way bigger cases than me. I'm just showing you one example where we have lots of bone loss, including bone loss around the adjacent tooth, and putting a block and having to advance my flap very aggressively to close this, and finally to finish off the case like so. You can, my question would be, how much of this bone actually continue to be remodeled and be viable? If you look at also the crestal area, the configuration of that grafted site versus the native bone, it does look different. And in fact, with this grafting material contacting the adjacent roots, there is certainly some amount of root resorption on the surface, external resorption, as you can see on the periapical film. So perhaps we need to change our mindset. Autogenous tooth graft bone, to me right now, I think is one of the closest to the gold standard, even though there are limitations. Of course, we can argue this and it will never end. I'm not saying that it is, but it is very close to the autogenous bone graft, but because it's not fresh, it is from extracted tooth. I do not use any barrier membrane. I do not think, as of now, after 12 years of practice, without using a membrane, I don't think a barrier membrane is necessary. And in fact, very often I close with some amount of light, amount of tension to stimulate my periosteum for successful GBR. We just have to think of it all over again, rethink our process, re-challenge ourselves, and see what other things possible. So we learn from nature. I learn by looking at nature. I look at the extracted tooth, and it is nature inspired. It is nature providing us the best raw material available. Of course, if you are extracting it and you don't understand the value of it, it's trash, right? And if you know now there is a value to this, you look at every extracted tooth very differently. And many of you, perhaps who have started to use tooth graft, will start to realize how important it is to look at those extracted tooth as potential grafting materials. This would then, before my eyes, considered a very useful graft material. Why not? Because in the early days, we understood keeping roots, bearing roots we accept leaving roots in the ridge. We call this root banking, root submergence technique, and whatsoever. And even in overdentures concept, in the 1960s, clinicians were leaving roots in the edentulous ridge, and it works because these roots helps. And today, with a great publicity and lots of lecture by some of my friends and my colleagues talking about root shield technique, you can see that leaving healthy root parts. I highlight the word healthy root parts. Then can they apply the root shield technique, whether you put in the buccal, like some of my colleagues have talked about, and of course some people put leaf proximal pieces to help to preserve interdental papilla, but there are limitations in the application. And in fact, in an inexperienced hand, it can be a little bit challenging and a little bit daunting. So it can make the technique, while it's very, very useful and beautiful in some of the colleagues' cases, but at the same time, it is technique sensitive. Can it be better? Can we do it on cases even with dehiscences, fenestrations, and so forth? And then when the root shield cannot be done, can I apply this using the root anyway? Yes, of course, we can. If you look at the root itself, the tooth, whole tooth itself, in 3 parts, it's no different from the natural bone, right? And now if we look at the composition of the bone graft, tooth graft, and to bone, you realize the close resemblance in terms of its inorganic and organic composition, and also the type. In fact, Kim et al. In 2014 shows a very interesting chart. I pull this from his article, where he looks at the X-ray diffraction. This diffractogram of different materials. You'll find that on the bottom, it shows the mandibular bone, the wave. Basically, if you look at this graph, the sharper the lines, and especially narrower the lines, the more minerals you have. It's trying to compare and show to you that the bone from the mandible and the dentine is almost similar. Okay. Well, this is maybe just one chart. Well, we also did, my group and I also did a similar one to look at composition. We actually did it to our graft material, the tooth graft that we have processed, and we look at the composition. And if you look carefully, there is predominantly, you look at the diffractogram and all the peaks, the main corresponding ones is predominantly hydroxyapatite and octacalcium phosphate, which is exactly the same as human bone. So if I take away the other part, which is the tricalcium phosphate, which is a very small component, you find that predominantly the main ingredients in our tooth is hydroxyapatite and octacalcium phosphate. So this is again hydroxyapatite. Okay, so what does the literature say? Actually, using the tooth graft is not new. It has been done in the 1960s. The only problem in the 1960s, the big question is how clean are these things to be put in the human body? But they were already showing us very interesting result, how this bone graft actually stimulate bone, how the tooth stimulate bone formation. I do not want to go into detail. I'm very sure Elio will have spoken before to some of you and show you very interesting laboratory results and even in vitro results from his study. And in the 1970s, they were also looking at all this, again, bone formation from using dentine. And of course, even in recent years, in fact, now there are more and more studies looking at using the autogenous tooth as a graft material. So these are some of these very recent years, very interesting articles, a lot of interest in this, looking at this. So you might want to look at some of these articles. So the characteristic of the tooth graft is important. If we take an extracted tooth from the patient and we're going to put it back and bury it, we need to be able to show that it lacks pathogens. And the TT in its process has his proprietary reagents, have created a process and treated it so that we are able to also counter check that the process is able to remove pathogens that are harmful to our body. So basically the cases that have been done very often, in fact, it's almost given that there is no infection that I have personally encountered. Moreover, the presence of dentine being tubular structure provides a capillary effect on its own. But the capillary effect can only work if the tubules are patent. If you take a dirty dentine and now your dentine is clogged with a lot of smear layers, those capillary effect would be minimal. However, if you now treat it through the process, this capillary effect opens up all these patent tubules, which provides nutrients and even all this fluid to flow through, allow this wettability. So in surgical process, you get this clumping effect of the graft and allows easy manipulation and placement. So once you've treated it, you should be getting a very clean surface, patent, open, and if you are able to see it on the right side, you could perhaps see just at the aperture of the tubules, you see a lot of meshes of collagen fibers. It is not to totally demineralize the surface, it's a partial demineralization, giving it mineral scaffold structure and strength, but at the same time, a mild demineralization, exposing the necessary organic structure underneath to support. So this is a natural, God-given substrate that we can use for graft material. And if you compare a treated dentine versus a zero graft, you clearly see the difference in terms of the surface architecture. As a dentist, you're very familiar with the picture on your right. And when the substrates are treated, you find that when you put cells on it, these cells proliferate. And not only do they proliferate, they differentiate and they spread over the surface, which is essentially showing good osteoconductivity. And very often using with the markers, cell markers, we can see that even in TT, the cells become osteoinductive. We have cells that are resting, becoming bone-forming cells, and I'll show you in a while's time. So, and in fact, it's proven in other literature where they look at the osteogenic potential of a demineralized dentine matrix, and they can show it on SEMs as well. In fact, they also use a very interesting immunofluorescence microscopy to look at the contents of the cell. They look at the actin F content, the microtubular structures inside the cells. The more active it is, the brighter it becomes. It shows that obviously the top one shows you the demineralized dentine matrix. You find that they're very active even from the very beginning, which is the key in terms of bone formation. So, and not only that, we found that this dentine bone, which we have in our hands, has actually contains BMPs. Isn't that what we want in bone formation? And this is one of the classic articles, I think, before Elio and the colleague decided to do this. I think this was the very first few articles that was published by the University of Milan, correct me if I'm wrong, where Elio played a big part in the looking at the BMPs and type 1 collagen, and it shows that these are actually present in our human tooth. And these are some of the data they have shown. You find that there's a cell viability with the graft material stimulating bone formation and also the markers. And the type 1 collagen we have seen already, this is a close-up for you. And presence of BMP. When the process of treatment with the TT process, the presence of BMP is actually exposed. So there is actually what we call a defossilization of the proteins that are trapped in the mineral content. And this is the process of partial demineralization for dentine graft. So because the BMPs is actually bonded covalently to the collagen matrix. So they are now all trapped in a osteoid environment. So when you now have a partial demineralization, this BMPs now is exposed, defossilized. Now this BMP becomes active when it contacts mesenchymal cells or cells that are inactive, and they transform into bone-forming cells. So why is BMP in teeth? This is because during tooth formation, BMP plays a very big part during tooth formation, from germ form to the finally tooth germ, and then forming the final tooth form. All this formation process, the BMP is participating in other form of growth factors. They are at the same time helping the organic matrix to form, they are also being slowly trapped when they become mineralized. So again, this is just to show you other studies, even on operative dentistry, that tells you that BMP is in there. And in fact, in 1990, they already quantified the presence of BMP and growth factors, or these growth transforming factors. And BMP is actually one of the superfamily in the tissue growth factors, okay? So BMP, many different types, but of particularly interest to us are BMP 2, 3, and 7. They play a big role in not just alveolar formation, but PDL formation, which is particularly interesting to me. And if you really want to look at what are the components in the tooth, please look at this article. This is one of the most comprehensive proteomic analysis of dentine. There are 400 different types of proteins, if I can remember correctly, and some of the key proteins that play a very big part subsequently in mineralization. So what can we do with the tooth? Of course, most of you in this room who use a TT will think that we can only use a powder. But I will also share with you how I do some of my cases, and I can make them into a block. So there are many in the market. How do you decide? How do you choose? There are considerations. Obviously, safety is number one. Make sure you use something that has been tried and tested. The preparation process should be easy, should not be very complicated like some of the machine, but you also do not want it to be too easy to the point that you worry that it's not clean enough, it's not properly done. Of course, you want easy maintenance. You cannot be hassle-free, that every process that you do, you need to worry about cross-contamination and so forth. And it should be cost-effective. And for you as a dentist to do that, doing the GBR with the tooth graft is a lot more time in terms of money savings, not so much of time saving, but money saving and success in your results compared to using other form of bone graft material. And of course, in every dentist and practice mind is always the price of the machine. It should be competitive. So I like to highlight to you that we use this graph because it's simple. Simplicity is the ultimate sophistication. So I want to eliminate, remove, minimize my process of patient. I want to remove the use of membrane. I want to remove cost for myself. I want to reduce, eliminate infection and failure in my cases. I will just quickly show you some of the clinical cases. These are things that you've done in your practice. It's probably quite boring for you. Socket augmentation, straightforward. Type 1 socket are the easiest. I will not spend much time talking about it. It's a done deal and it's always very predictable in our hands. More challenging are the type 2 and type 3 cases. But type 2 are quite interesting cases. I'll show you how I'm doing it in our practice today. Maybe some of you are doing the same way. So type 3 is the difficult one, is when we tend to do staged, whereby I will actually raise a flap. Both type 1 and type 2, I do not raise a flap. But type 3, I raise a flap because I need to make sure I have enough soft tissue to contain my graft. Straightforward type 1, we just extract, take the tooth out, prepare it, put it back, and then I do not do any primary closure. We just do a fibrin membrane. Today, I don't do that as well. I just put a collagen plug and do a cross stitch over it. And this can be opened up easily in just 3 months. We get a very nice consolidation. It's actually very repeatable. Even in endodontically treated teeth, same thing. We can do it. And in fact, there's publication by the TT group as well. It's a multi-center study. If some of you do not know this, you perhaps can get the references from Diego on the use or even endodontically treated teeth for our cases. Like in this case, a tooth was extracted and a cleanup grafted into the area. And this is a site after 3 months. You can see some of the graft materials in part of it still there, but if you take a Peristeum elevator, it's scraped. It doesn't really come off. You get nice bleeding from the side. You drill into the bone, it bleeds, and placement of the implant is straightforward. And of course, with consolidation of the graft, you can see a nice outcome and you compare it to the surrounding native bone. And this is a soft tissue that we get, no exfoliation of the graft material or of any sort, and the site is clean and healthy, and the placement of the implant. So it's a repeatable procedure for us in our practice for this kind of straightforward class 1 socket. And this is the CT scan that we've done for the patient. Same thing for the other one. Whether you choose to extract the tooth, grind it up, and then place the implant on the same visit, it is possible. You can do that if you like. And then closure, without a primary closure, we mostly use collagen plug again, or we use a PRF membranes and closure. And this is what we get all the time. So when you open up, you should have a healthy soft tissue. And then final. Obviously, sorry about the prosthetic work, not the most amazing, but you look at the soft tissue, we have actually gained more than before. If I may show it to you. You can perhaps see that the soft tissue effect is even better before the patient had the tooth extracted. Again, sometimes the site is very badly infected. I just extract, I keep the tooth, I only graft, it goes in when the soft tissue has covered over the area, almost like an early implant placement technique. So we open up again, scrape off the area clean, remove all the granulation tissue, place the tooth graft material in. You can see on the X-ray. And this is what we get. Always a clean site. And then you can raise it up and then place your implant. It's repeatable again and again. And what you will see also over the years in your cases, you'll find that when there is supposed to be a cortical bone, there will be a cortical bone. It's not like you put a graft material, you get a dense layer, which doesn't really form a cortical and cancellous layer, which you don't see with the tooth graft that we have done. What we have shown, I will show you now, is another case, a 70-plus-year-old lady with no medical history, but she had a very periodontally involved teeth. This tooth is very, very shaky. And if you look at the CT scan, if I may show you, you will agree with me there is no buccal bone and no palatal bone. But however, we are lucky because she still has soft tissue holding the buccal and palatal part of the root. So no flap was raised. It was only extraction very carefully, not to destroy the soft tissue. And from the socket, we place the extracted tooth after treatment and place it back into the site, as you can see. And then we put a collagen plug on top and close it up. And this is what we had after 5 months. As I mentioned to you before, you start to see a buccal and palatal wall, because this is a major destruction. If we waited a bit longer, I think the result would be better, because at the end of it, I can show you on the CT scan. And when I raised the flap, I was a little bit shocked to see the presence of a buccal plate. And you find that we are able to maintain a good width, and also if the presence of the buccal plate exists, we can hold the area, we will have a good maturation of the site, a stable site with no pressure coming on for the buccal soft tissue, placement of the implant, and this is the final result. You can, as I mentioned to you before, you can see a formation of a buccal plate, a dense cortical plate, which you might not see if you use other kind of bone graft material. So what have also evolved in our practice is that from our own animal study, we realized that I do not need to use only particulate. I can also do it in a block form. With the block form, I'm not worried about change of shape of my structure. I also can provide a shield to the buccal aspect to prevent the collapse of the soft tissue, of the graft, of the ridge. So what we've done is, after the tooth is extracted, we keep it, and then a month later, when we raise the flap, we clean up away the granulation tissue. We take the tooth, the shape that we wanted, and since the shape of the tooth is already there, and the socket has not changed much, I can slice it, and then I take this, instead of putting into the grinder, because the TT has to go through a grinding process, I let it go through a ghost grinding process. Then when it's finished, when a receptacle has moved to the front, it's supposed to show me, oh, I have a granules there, right? Before we start the process of treatment, of the step-by-step proprietary process. Then I take the root, I put it back there into the receptacle and start the machine. So we run it through and we're able to treat and do the partial demineralization. And once we insert it back, it fits in with perfect fit with no movement because it is snug fit into the same extraction site. And then we close the flap. And when we finally open it 3 months later, we open up, this is the center picture that shows you the site after the grafting. We did a trephine of the area to put it through a histology analysis, and this is what we get. We get a quite beautiful bone formation, I must say. You see the bone bridging between the granules of the dentin particles. And this is the final outcome. We can also do it for cases where there is buccal dehiscences. Extraction of the tooth, you see a buccal dehiscence, you obviously can't do a root shield with this. So, but we can create a pseudo root shield. So what we did is we took the root, I told you the same process, treat it, insert it back exactly where it was in the original position. Implant is inserted, and then we put a soft tissue, cuff, and close it. And this is what happened when we open it up about 3 months later, and the implant is completely buried. We literally had to hunt for the implant. So you have a situation where the bone is well encased around, and because of the presence of the very good osteogenicity of the tooth graft. And the same with the other cases. Again, extraction of the tooth, placement of the implant in the correct position, place the bone graft, and then the result. So we can create this very predictable result from the tooth graft. It is something that in your hands, it is not a complicated procedure. It's not a procedure whereby you have to go through, it's not rocket science. And even for lateral augmentation or vertical augmentation, again, due to time constraint, I know I'm limited in terms of my time. I will have to speed it up. I will show you a couple of more cases. The lateral augmentation, like lower incisors, easily can give us about 1 cc of bone. So you can do whatever technique you want. Better you want to do a ridge split, and then place the implant and place a graft material and then close it up. You can do any technique that you want. So, but when we close nowadays, because I also want to explain that in our Asian patients, a lot of them lack keratinized gingiva. So what we do is we deliberately make our incision at the keratinized gingiva, separating keratinized gingiva on the buccal and keratinized gingiva on the lingual. And when we close it back, we do not do primary closure, but we are protected underneath by a fibrin membrane. This keratinized layer on the lingual, keratinized layer on the buccal, what will form in between? Keratinized gingiva. So we will increase our keratinized tissues easily through this technique. And with this, again, my colleague did a soft tissue procedure, again, keratinized to keratinized and split the tissue. And though he doesn't allow primary closure. And this is the healing that we can get from the keratinized tissue and the final prosthesis. Okay, second last point, sinus of grafting, I probably have to skip due to time constraint. Because when we do a lot of lateral augmentation, doing vertical crestal lift, very often we have a problem because when you lift from the crestal situation, you do not have more of the wall or the bone exposed. When you have less walls exposed, the less likely to form bone. So this is particularly a problem when your sinus is very broad. So when you have such a situation, you have a problem of good bone formation. So when you have a wide sinus and you do a crestal lift, you have what we call a low osteogenic site, contrary to what you believe that the sinus is a high osteogenic site. So in those cases, I tend to use the extracted tooth as my graft material. So like ridge like this, which is very, very broad buccal palatally, I tend to use a tooth as a graft material to prop it up. And this will help us to get a lot of bone. So this is a case in point. Okay, I just have to skip this due to time constraint because I would really like to move to the next point, which is one of the most exciting points in the development of tooth graft. And this has a lot to do with using the tooth graft for periodontal regeneration. And we know that periodontal regeneration is always very challenging. And this is what we always believe. And we transfer the guided tissue regeneration concept to guided bone regeneration concept, which is unfortunately not necessarily the same. There are subtle differences. And the use of this material has been actually very well publicized. However, periodontal regeneration is not as simple as you think of just applying a gel and something magical will happen. And this is what I did many years ago. I used the Endogain. Well, is this success? Not in my eyes, but in my eyes of my patient, it has stayed in his mouth. It is success to him. It is good enough for him. But the bone that is formed is still not ideal. Which perhaps even today, if this patient walked to another clinic, the dentist might ask the patient to extract the tooth. But even though the tooth now has a type 1 mobility, it is not the kind of mobility that we were expecting in the very beginning. On the potential of periodontal tissue repair, I will have to skip. We know the importance of the different factors to have a successful outcome. But I would like you to look at this article. If you have the opportunity and you have a chance, please look at this article. Very interesting result. Basically, it's telling us we do not have to accept that periodontal repair is the outcome. We can expect periodontal regeneration. The periodontal ligament, periodontium has a high potential to heal and regenerate. And as long as we have all the right factors, proper space provision, if you use a graft material, the right graft material, how we manage the site, the removal, keeping it clean is key to have this formation. So the biological factors are actually more important than the mechanical factors. And so you need an ideal material to assist. In this case, you call it biologics. And in fact, if you look at our tooth, it's actually something like a biologic. It is easy to use, moldable, space providing, it's compatible, it's bioadhesive, it's porous, and it's also biodegradable. It actually fulfills everything he just said. And if you look at the effect of this formation, another interesting study, if you have the chance to look at it, is on the dog study though. They found that actually the periodontium putting the right biologics trigger regeneration. And actually, it's not so simple. So in this figure 5, he actually explained to us that when you want to have regeneration, it's not a single cascade. It's multiple cascades that overlap in a sequential manner. It is not, or because I put a gel, everything will happen in its order. No, different chemicals play different roles at different parts and timeline of regeneration. So it is a very complex procedure. Yet the tooth in its very simple form fulfill this. And this is confirmed by the study done by Xi. Actually, they use the dentine barrier as a periodontal regenerative material. So what they did is they created a periodontal infection model in the dog, and they cleaned the root, the bifurcation area, and they used the root as plates and secure and stitch over it. They were able to trigger bone formation with histology. So please look at the article very quickly. I shall not waste I have not much time to talk about this. But the key is that the tooth itself has a very interesting protein. It's the presence of dentine sialoprotein. And this dentine sialoprotein actually stimulates and differentiates human periodontal ligament stem cell. Interesting. So have a look at some of these articles. It changed your mindset about how we look at the use of the tooth graft for periodontal regeneration. I call it a tooth for tooth concept in a very simplistic manner. Some of the words here perhaps wrong. Some of my colleagues will laugh at the language that I use, but the idea is there. So you can see cases like this on the lower left. The patient had a premolar that's extracted because it's buried. And of course, there is a very bad defect after the extraction. And this is the pre-op picture. You can see the stripping of the mesial root of the molar, devoiding of any upper half lacking root, any bone or periodontal ligament. So you can see that after the extraction, there's basically raw denuded root surfaces with no periodontal tissues, of course. And this is what happens. We put the graft material in, and this graft is the extracted tooth that we place back into the area. And this is how it looked like after the surgery. You can see that there's no periodontal ligament. It's just a bone graft next to the root. Okay, so this is healing after 7 months. We are able to start to see the early changes. So you can see that the root is now, you can see delineation between the crown and the graft and the root. And you start to see a more distinct line of a periodontal ligament formation space. And other cases as well. So like this, again, extraction, and you can see the destruction of the distal part of the root. So there is no more a bone on the distal aspect of the premolar. So when we place, again, the tooth graft back into the area, it again does not show anything. In fact, under normal circumstance, putting any bone graft material, you're very concerned that there might be external root resorption around the premolar. So this is what we had after 3 months of placing of the graft. The bone had consolidated and we placed the implant. But you can see the bone around the root is obviously not forming anything other than the fact there's an increase in radiolucency around it. So implant is placed, but we started to follow the case over time. And when we took an X-ray, we start to see a very strange phenomenon. We saw a formation of a space between on the distal aspect of the premolar root. And when we did a CT scan, we start to see formation of this space, which is getting clearer and clearer. So it is quite interesting that we see some of this situation. Unfortunately, in a human, we're not able to the patient will never agree to let us find out the premolar for us to look at the regeneration, but at least from the radiograph, we can see a drastic change from before and after. Again, another case, I just quickly run through. You see the severe bone loss of bone on the distal aspect of the canine. The premolar has a furcation involvement and also tooth was mobile. And there was pus exudate. Well, the tooth has to be sacrificed, and then we did the same thing. So again, you see after the grafting, the formation of the periodontal ligaments on the distal of the canine is more evident. And this is the outcome of the area. So from before and after, we gain not just probing depth. Probing depth is not critical because probing depth doesn't mean that you have periodontal regeneration. You just have something to stop it. But important, what's underneath. X-ray is what we have right now. So and the very last case I will show you is again this case with a severe resorption and loss of the tooth. So this is what we have. We're trying to keep the upper right central incisor. And you see that there is a lot of bone loss around the area. I can show you surgically. You can see that the bone loss around the upper right central incisor, the mesial aspect, is very far down mesially and also buccally. So the tooth that were taken out, you can get a very generous amount of the graft material for both the ridge augmentation and also the lateral, also for the root, where we place the graft material at the proximal and on the buccal aspect. So this is what we have in post-op within the first 1 month. And if you follow through over a period of time, you'll find that there is consolidation of at the bone graft at the mesial aspect and also at the buccal. And when we finally ready to place the implant on the augmented side, you can see the bone regeneration that we have. So this is what we have actually from the other aspect. And you can see on the upper top part, there's a little black thing, and that's actually the implant with the cover screw. So this is before on the left, and this is on the right after the regeneration. So we can get good bone regeneration around periodontal regeneration as well around the tooth. If we can save it. We can use a tooth to save another tooth and not necessary to throw it all away. So histology, I will not talk too much about it. I'm sure Elio has shown you many histology. I will skip all these things. Okay, so yes. So basically, this is the outcome we can achieve. Radiographically, we can get good result. The tooth graft has the same behavior like the autogenous graft. Yeah, and of course, if you compare to the other graft material, there are concerns because of the difference in terms of the density radiographically to the native bone. So in conclusion, the autogenous graft is biocompatible and there's no risk of rejection if properly done. Easily available source from the patient. Of course, it's from the own patient, there's no worry. And in fact, I will tell you, patient's acceptance for this tooth graft is actually almost effortless from my side. When I speak to the patient, now the patient is willing to extract the tooth because there is a value to that tooth. It's not going to be thrown away. Yeah. So in the end, I'd like to say to simplify your bone grafting procedure, and we can do more, in fact. So in the future, I hope to share with you more examples and more updates of the cases that we've done in our practice. So everything should be simple and not simpler, okay? So yes, with this, I'd like to end my presentation. I'd like to say thank you very much for your kind attention. If you have any question, please feel free to let us know. And yeah, so Diego will be, and myself will be able to answer your question. Thank you very much.
Thank you very much, Dr. O. Oh, for me, it's very nice for me to see many participants for different countries for different time. Thank you very much for USA. It's very early. It's 4 o'clock in the morning, and it's very nice. Thank you. I hope the webinar was interesting for all. And please, for all questions or simple information, send me email. And keep safe. Have a nice day. Have a nice night for all. Thank you so much, Dr. Ho.
You're welcome. Thank you very much for your kind attention, everybody. Thank you.
Bye. Bye-bye.
Okay, bye-bye.